First of all, I am thankful to Dr. Bharti Kashyap for giving me this opportunity. My topic is pediatric lens subluxation, preservation of the bag. And time allotted is 6 minutes. I will be able to show at least one video. This is a case with the extreme subluxation of the cataract. And here we have to decide whether we want to preserve the bag or we want to do lensectomy, anterior vitrectomy and transscleral fixation of IOL. But I planned that I will like to preserve the bag in this case where it is almost 300 degrees subluxation. If you see it very carefully. So with this aim of preservation of the bag in mind, I planned cataract surgery for this child. It was difficult to do rhexis because capsule was quite thick. So capsule was, I hold the capsule with the forceps, retinal forceps, with which they remove the epiretinal membrane and then start with the continuous curvilinear capsulorhexis. And with each segment, after little doing rhexis, I applied hooks to the rhexis margins because it was too difficult to continue with this. So hook was applied to the rhexis margin and I continued with the continuous curvilinear capsulorhexis and I could complete the rhexis. And then I applied other hooks because we wanted to stabilize the capsular bag and do hydrodissection and removal of the cortical material from the capsular bag. And with the cortical aspiration was done with irrigation and aspiration. And of course we have to do it gently. Because now we have to place we have to place the AMS segment or 2 eyelid Cioni ring for such a patient. Additional iris hooks were applied. Capsular bag was filled with viscoelastic and with the polypropylene suture, which was needle was placed, and then it was this is for tying the AMS segment. I planned that I should apply 2 AMS segment. And then this AMS segment was implanted into capsular bag and the suture was tightened. If you tighten it much more, then there may be fear of even a torn capsular bag, so it was gently tied and appropriately placed. And another segment was placed opposite to the first one. The same way it was fixed with the polypropylene 90 suture, which was used in this case. On the opposite side, and then IOL, hydrophobic acrylic IOL, was placed into capsular bag. and removal of the viscoelastic, as well as there was no vitreous in this case. Otherwise, sometimes we have to do vitrectomy. So this was the final view of the IOL implantation in such a severe case. So I could do it successfully because I kept in mind the second option. I will always give the second option of lensectomy, vitrectomy, and anterior and transcleral fixation of IOL. First, always try to do the natural implantation of IOL into capsular bag. That is what I think in this case I did. Thank you so much.
Thank you.